Okay, I think we're recording. So without further ado, I will hand over to Alex if you want to start. Thank you.
Thank you very much, Jenny. I'm just going to find the right one. Here we go. And could you just confirm that that is
Yes, we can see that. Thanks.
full screen and everything, and you can hear me okay?
Yep, perfect.
Okay. So I'm Alex. I'm one of the consultant vascular surgeons based in Hare Myers. I am also just the recent ex-clinical lead for the network. Thank goodness. So I've asked to do this really just to give an update to people in primary care who we obviously hear a lot from, but don't see very much. A lot has changed in vascular, and we're well aware that services in vascular are not very good right now. In fact, they're probably pretty rubbish, and I'll try and explain why and what we're trying to do about it. I think the main thing, to be honest, is to update you on the service, because there have been major changes, and then a very, very brief update on, I think, probably the key topics and how we approach them, but as they might be relevant to you in primary care. And I think those are generally, leg pain and claudication and varicose vein disease. At least that's our perception of what it may be. Obviously be very keen to know if that's not right. And obviously I'd be very pleased to answer questions at the end as well. So huge changes in vascular in the UK in the last decade or so, even longer. So the old model was you had a vascular surgeon or two scattered around in most DGHs. Maybe some bigger hospitals had a separate unit, and there was lots of work in the early 2000s which showed that the outcomes from vascular intervention in the UK were pretty crap compared to the rest of the world, and it was largely due to the fact that we hadn't really modernized and centralized, in a way, vascular services that often weren't 24/7 on calls. A lot of emergency stuff was done by general surgeons. So that led to some pretty painful reorganization of services across the UK. And again, we've been a bit late to come to that in Scotland. The first unit to really do it was the unit based in Glasgow, and they've now all moved to the QE. And then it's happened since in the southwest. So there used to be vascular services in several hospitals across all three health boards in the southwest. And after a lot of toing and froing, there is now one network that covers NHS Lanarkshire, Ayrshire and Arran, as well as Dumfries and Galloway. Now, all the hospitals still have vascular services in the sense that we run clinics and diagnostics everywhere, but all the arterial surgery is done in Hare Myers. So it's what we call a network model, where you've got network hospitals where clinics and diagnostics are done and some minor interventions, and an arterial centre where people come and have the big operation where more specialist care is needed. We also include the Jubilee. We do some of our thoracic stuff there as part of the network as well. This is a sort of vague diagram. It kind of gives you an illustration of how difficult it was. We get our fingers into lots of different places. Obviously, the CKD population is a big part of our work, as well as the more sort of regular vascular stuff, claudication, limb-threatening ischemia, etc., aneurysms and what have you. But we're also expected to support a lot of other surgical specialties who might run into bleeding and what have you. So we've had to develop a lot of protocols and transfer things for everyone across the region. And it's taken a long time to get this vaguely into shape. One of the key things that has changed certainly in Lanarkshire is that the diagnostic base that we have has improved. So we now have a vascular laboratory, which is really a critical part of any vascular service. And this offers easier to access, non-invasive diagnostics for people with suspected peripheral arterial disease, venous disease, aortic aneurysm disease, etc. Before, and this is even when I started as a consultant not that long ago, we didn't have this, and we were still reliant on CT and MRI for fairly, for almost everything, which was really not appropriate. But we've managed to recruit a team of 2 vascular scientists. Those are the people who run and work the lab, and they can offer ultrasound of all the circulation in the body, as well as pressure assessments, which make life better for the patients. They don't need blood tests. It's non-invasive, it's quick, it's dynamic, etc. But it's freed up a lot of capacity in radiology as well. And one of the things that we've done is also slightly changed our model for accepting referrals, where sometimes, and some of you may have noticed this, we will vet directly to a test because of the waiting times for clinic. Now, there is already an established lab in Ayrshire and Arran and also in Dumfries and Galloway. So the one in Lanarkshire is one of 3 that are now up and running. The workforce is bigger. We obviously have most of all of the inpatient vascular stuff is done in Hairmyres, where there's a large vascular ward with 30 beds in it. We've got access to beds in level 2 and level 1. We have 2 clinical nurse specialists in Lanarkshire, 2 in Dumfries, and 1 advanced nurse specialist or 1 advanced nurse practitioner, I should say, in Dumfries, and 1 in Ayrshire and Arran. And that is something that we're looking to expand. We're also very dependent on a large allied medical professional team as well, specialist physios and OTs, certainly in the hub and in the network hospitals, where we do sometimes discharge people for rehabilitation after an amputation, typically. I've already mentioned our vascular technologists, there are orthotists, etc. And we are looking to recruit physicians associates as well for reasons I'll come back to. In terms of medical staffing, we have consultant interventional radiologists, vascular anaesthetists, and surgeons. Now, all the surgeons are based in Hairmyres, but we have responsibility for spoke sites, as it were. So I actually cover Dumfries and go down there a few times a month for all-day clinics, but all areas are covered, but all the surgeons have a footprint in Hairmyres as well. We have 7 middle grade staff on 1 rota level, so it goes FY1, registrar, then us, and we're trying to increase that, but money is tight, obviously. There are some major risks. So both vascular surgery and IR are in a state of fairly acute and chronic crisis. There is a sort of basic population to surgeon ratio for vascular surgery, and it's supposed to be 80,000 patients per vascular surgeon. If that was the case, we would need well over 65 vascular surgeons in Scotland. At the moment, there are only just over 30, and quite a few of them are not far off retiring. IR is not much better. In the network, in Hairmyres, we have salaries for 12 consultant surgical posts, but only 5 have been filled for some time. So we're running at a pretty major deficit. And you can imagine the impact that this has on our ability to provide clinics, lists, the on-call as well. It's not a great deal better for interventional radiology. We still do not have an emergency, a 24/7 rota for IR. And another big thing that we've struggled with is the provision of vascular access care for CKD patients. That's perhaps not something so relevant to you, but it's been very difficult to get that to work across the piece, particularly given that renal is based in Monklands and we're based in Hairmyres. There are plans to start offering hemodialysis in Hairmyres as well, but that's something a bit further down the line. The sort of key areas of particular concern, the really big one is the outpatient waiting list. So just in NHS Lanarkshire, there are well over 1,200, 300 people waiting to see a consultant vascular surgeon in clinic. At the moment, people are having to wait, we estimate, 1.5 years for a routine clinic appointment to see one of us, 3 months for an urgent review. Now, we do have a hot clinic, so for people who it appears are at immediate risk of limb loss, we can see them within a week or 2. But for anything less than that, it's a long wait. And this is the reason that we're really trying to change the model in which we deliver outpatient vascular services. Our time to limb salvage intervention for people with limb-threatening ischemia is very much longer than it should be. This is multifactorial. It takes a long time to get these people in. We're getting their test done pretty quickly, but then often it's finding space for them to have an angioplasty or a bypass. That's the problem. And there is also a long waiting time for other time critical interventions, such as aortic aneurysm surgery, carotid surgery, etc. To say nothing of poor people suffering with venous ulcers who may be suitable for intervention. We have been trying to mitigate things. As I've already said, we are trying to massively increase the role of our supporting clinicians. Our CNSs, vascular specialists, have been particularly useful. I don't know what we do without the two that we have in Hermeyers, the three we have in Dumfries, and the one that we have in Esher and Arran. I think in the future, they will generally be the first point of call for most patients coming to clinic, and will then almost do a second vetting to see who really needs to see a consultant sooner rather than later. As I've said, we have developed a hot clinic. So if you refer someone and the story concerns us enough, we will book them onto an emergency or hot clinic, and they will normally be seen within the week or 2 weeks. We run one of those every Tuesday in Hermeyers, and that's covered by the on-call consultant. There's one a week in Esher and Arran, and there isn't one in Dumfries. And clearly, we also go out to all the hospitals to try to minimize the amount of travel that patients have to do. They should, in theory, only have to travel if they're coming up either for a high-stakes pre-assessment visit or for an operation. We are now trying to improve our vetting. We're always very, very grateful for detailed information provided in the referral letter. That can help us a great deal in choosing an appropriate time to clinic. And we are, when appropriate, vetting to test, particularly to the vascular laboratory. We probably went a wee bit too far to start with this and started vetting a lot of people to test. And then instead of just having a long waiting list to see a consultant, people ended up having an increasingly long waiting list to get to their test. So we've slightly rowed back on that. But ultimately, we're looking to expand the vascular laboratory and again, try to do as much as we can vetting to test. A lot of patients referred will turn out to have normal non-invasive imaging and will therefore be suitable for some written advice instead of needing a clinic appointment. So this has all been with a view to reducing this outpatient waiting list. That we are working on sort of new pathways nationally. And there's a group called the SDG, the Special Delivery Group, which some of us are part of, and it's kind of focused on 5 key pathway areas. The most relevant ones for you guys are these ones. Probably in order of importance, I'd definitely put venous leg ulceration up there. This is probably the area of the greatest unrecognized burden and suffering for the population out there. And the provision for this remains inadequate. I'd probably put CLTI above aortic aneurysm disease. So CLTI is the new term for what we used to call critical limb ischemia. And then low down would be abdominal aortic aneurysm. We're fairly fortunate in Lanarkshire already with our provision for claudication. The NHS claudication clinic that was set up by Eamon Brankin and Roy Scott, my predecessor, has been a real success story actually, and is actually being used as the national model for Scotland. And it's definitely the future. And I'll come back to that in terms of why an outpatient and community-based claudication clinic is the way forward for this particular syndrome. So with that in mind, I bring this up specifically because it's definitely the most common referral we get. So, I mean, I'm sure I'll very briefly go over this. So you all know what intermittent claudication is. Exertional pain only felt in the muscles, most commonly the calf muscles, because the superficial femoral artery is most commonly affected. You can feel it in your buttock muscles, your thigh muscles, sometimes in your hip as well if you've got a more proximal occlusion. It is always relieved by rest, and there's usually a fairly fixed distance or time of effort that will bring it on. You don't get it in your feet. That's a common sort of misconception. Whereas chronic limb-threatening ischemia, when there is inadequate basal blood supply, as in not supply-demand mismatch, you will feel in your toes initially. So the combination of the stereotype history, history of cardiovascular risk factors and previous major adverse cardiovascular events is normally enough just to make the diagnosis. Again, examination fairly basic. You don't need an ABPI to diagnose it, but the ABPI is quite good at ruling it out. Or again, if we've got easy access to it, it's quite good for reassurance, really. It's got a lot of mimics. So again, a large chunk of our clinics are spent trying to work out what the claudication mimic is. By far the most common ones I have highlighted in bold. I mean, we get a lot of people who just have physiological cramping, which is normal. Just needs reassurance, really. A lot of arthritis. Again, radiculopathy, nerve root compression, very, very common as well, and slightly less common, but increasingly with the changing demography, we're seeing a lot of people with spinal stenosis who often present with very typical claudication symptoms. That also works the other way around. We do occasionally see people who present with fairly late stage ischemia who have been getting managed for spinal stenosis in error. So CLTI, this is what we're really looking for. I'll come back to, so we don't worry about claudication much anymore, or we do, but not acutely. But CLTI, these are the patients that we're trying to identify. So it's very clear now that we should be focusing our resource and effort in identifying people who have CLTI, chronic limb-threatening ischemia. The new name I think is better because it tells you what it's all about. This is when the perfusion to the limb becomes so poor at rest that you start to get tissue damage. And so it's defined by that, really. So ischemic pain, which is almost invariably felt in the toes or the forefoot, or the presence of ischemic tissue loss. That's it. You don't need an ABPI or any other test to diagnose it. It's very much a clinical diagnosis. But we know that this is where there is the biggest benefit from seeing a vascular surgeon and intervention being contemplated. It can be difficult to diagnose. There's a lot of mimics. Again, I've highlighted the common ones in bold. I think the really big one for us is peripheral polyneuropathy, almost invariably associated with diabetes. The two can coexist. And this is really where the role of the lab and non-invasive testing is important. We're getting a lot of people with diabetic foot disease, etc., a lot of whom will have ischemia as well as neuropathic problems. And that these people do need to see one of us to decide what's going on. And again, part of the reason for really going a bit all in on the vascular laboratory has been to try and reduce the time from referral to formal diagnosis of CLTI. So a little bit about what the thinking is these days for peripheral arterial disease. 40 years ago, I think, people thought that atherosclerosis was a purely degenerative disorder. You started with a lipid streak, or with intimal injury rather, that progressed to a lipid streak, that progressed to a mature atherosclerotic plaque. The plaque would rupture, there'd be a problem. We now know that that's very much not the case. Your arteries, like any tissue in your body, can and do heal. In fact, by the time people develop symptoms or acute problem, they will have had atherosclerosis for a long time. All the various plaques in their body will have gone through many cycles of exacerbating, healing, stabilizing, etc. And we know, in fact, that quite a big, large, juicy plaque can regress and then stabilize. So things do get better. And really, whether or not you develop MACE, which is major adverse cardiac or vascular events, sort of shorthand for myocardial infarction, stroke, acute limb ischemia, that kind of stuff. It's probabilistic. So the more plaque events, the more plaque progression, inflammation you get, the more likely you are to have a plaque rupture and thrombosis that will lead to an acute clinical event. So if you can promote plaque healing, you'll get fewer acute plaque events and therefore a lower probability of having an acute clinically overt event. It's also become apparent that the arterial system is incredibly good at collateralizing and remodeling. We will commonly see people who've with us for other reasons who will have completely asymptomatic, fairly impressive occlusions. So your body can open up alternative channels for the blood to get to whatever bit of the body we're talking about very readily. And that whole process is impaired by things like cigarette smoking, uncontrolled diabetes, hypertension, or the absence of a statin, etc., etc. So really what we're trying to do is promote vascular healing and reduce vascular injury. The best analogy I can think of, just to explain to patients, is a bit like having an injury on your skin. If you look after the wound, dress it, don't pick it, it'll heal. If you carry on picking it, getting it dirty, etc., it'll just get worse and worse. So really it's about promoting a sort of healthy anti-atherogenic environment. And with that, the vast majority of people with atherosclerosis will stabilize or improve. And we really think about all of the atherosclerotic syndromes in terms of stable and unstable phenotypes now. And it doesn't matter what territory you're talking about. In the coronaries, there's stable angina, what we call chronic coronary syndrome now, versus acute coronary syndrome, which includes acute myocardial infarction, ST elevation MI. In the limbs, intermittent claudication versus CLTI. In the kidneys, chronic renovascular CKD. In the brain, well, we don't get brain angina, but when you have an acute plaque event, you may have a TIA or a stroke. And what's become abundantly clear from the literature is that if you have a stable phenomenon, i.e., chronic coronary syndrome, intermittent claudication, renovascular disease, intervention has limited, if no role at all. It's become increasingly clear that interventions, stenting, bypass, does not affect prognosis in the least. What does affect your prognosis is when there is a sudden change in perfusion caused by a thrombosis on an acute plaque, where there is a sudden change to the natural order of things. If something has developed chronically, it will have collateralized, there won't be tissue injury. If there's a sudden reduction in blood supply, it will cause tissue injury, be it in the brain, the limb, the gut, or the heart. And that is where there is good evidence that intervention is useful, and therefore where we are trying to prioritize our resource. And there's now plenty of very good evidence to back this up. In the coronary literature as well, we know that even for fairly advanced coronary heart disease, intervention, be it by PCI or bypass, generally does not change your prognosis. It does not make you live longer or reduce your risk of having a myocardial infarction. What does is stopping smoking, doing physical activity, watching your weight, all the lifestyle stuff, and statin therapy, and some other new lipid-lowering and anti-atherogenic therapies that we'll briefly talk about. But intervention does not change prognosis in the context of stable disease. And there are even some questions now if it changes symptoms. Certainly in the peripheral literature, we've known this for a long time. We used to do a lot of intervention for claudication, but it's become apparent from randomized trials that in fact any benefit on symptoms is usually fairly short-lived. And because you've gone in and injured the arteries with your surgery, the bypass graft itself, the angioplasty artery, is rather prone to sudden thrombosis later on. And again, if you have a sudden thrombosis, your risk of an acute event, acute limb ischemia, is higher. So there is undoubted evidence now that an intervention for claudication will increase your risk in the future of acute limb ischemia and limb loss compared to no intervention. And when I say intervention, I mean an operation, a procedure, not medical therapy or optimal medical therapy. So we now almost never do intervention for claudication because we know that it doesn't help very much, and it is likely to cause harm in the long run. There we go. Oh, my slides are stuck. Oh, here we go. So we've got a short term now for, a new term for grouping all that medical therapy together. Lifestyle modification, antiplatelets, managing hypertension, etc. BMT, best medical therapy or optimal medical therapy, and really the most important thing of the lifestyle changes. Statins and antithrombotic therapy are important, probably in that order. Again, I spend a lot of my time. I can't spell prescribing. number one, explaining a diagnosis to a patient, why we're not recommending intervention. The natural logic of there's a blockage, we should do something about it is quite hard to argue against superficially, but we are getting better at that. Another big part of it is convincing people that statins are worthwhile. I think it's now, beyond any doubt at all that statins are the most powerful disease-modifying drug available. They do reduce your risk of MACE. They do prolong your life, unlike surgery, by and large, for stable disease, not for unstable disease. And the big problem we tend to have is convincing people to take them at the appropriate dose. There's now clear guidelines and data. There was a good summary in the BMJ a few months ago. From the PAD point of view, if you have symptomatic PAD, you don't need to do an assigned score. You are at de facto very high risk of major adverse cardiovascular events. And the correct dose of statin is 80 milligrams of atorvastatin or 20 or 40 milligrams of rosuvastatin plus or minus ezetimibe. It's clear that there is a dose response effect, and the more you can get in, the better. We still do test for lipids. Really, you want to have your LDL level as low as possible. It's a good way of assessing compliance as well, and there will be some people who have a more complex dyslipidemia that will need to go to the biochemistry clinic or the lipid clinic. The big unknown is PCSK9 inhibitors, like inclisiran. These do work very well, and unlike a lot of the other cholesterol medications, they have been proven to be associated with a reduction in the risk of major adverse cardiovascular events and probable increase in prognosis as well. But they remain expensive and only for limited use at present. That will be something that will change in due course. So we would typically send the rare patient who is genuinely statin intolerant to the lipid clinic for consideration of PCSK9 inhibition, or for someone who genuinely has a complex dyslipidemia. Again, this is something I hope I'm not teaching how to suck eggs. I find we get fewer statin skeptics these days. Usually they've been mis or disinformed. They're a bit frightened, and simple explanation can help. But one big thing that I've started doing is, instead of talking about it being all about their cholesterol, is to focus more on the fact that it's not really their cholesterol. The cholesterol is just a biomarker of cardiovascular risk. I mean, unless you've got extremely severe dyslipidemia, it won't cause any symptoms. So really the purpose of the statin is to prevent you having a heart attack or a stroke. One study that I do actually sometimes refer to with patients was done in London, and here they randomized people who had an indication for a statin to either an empty box of just an empty bottle, a placebo, or a statin, and they then looked at the different rates of side effects, and you can see that people who were taking a placebo had an identical rate of side effects to people who were taking a statin, and even people who weren't taking anything at all still had a degree of sort of nocebo somehow. And this people find quite reassuring. So that, like, true statin intolerance is very rare. Statin-induced myopathy is fairly rare. And if you just explain the nocebo effect, I tend to find, and also the benefits that they have in terms of reducing MACE, people generally will accept a prescription. So finally, a minute or two on venous disease. So if we're talking about varicose veins, there is government guidance written by our former CSO. A large proportion of the population over 40 have varicose veins. There are 30 vascular surgeons in Scotland. The basic arithmetic is that we do not have the resource to treat everyone with varicose veins. It's probably also not sensible given our healthcare system. So a very clear line has been drawn. So this is the CAP, Clinical Etiology, Anatomy, Pathology classification of venous disease, which is most commonly caused by varicose veins. We will not see someone who has C, clinical, this is a clinical stage, is this the 0 to 6 number. We will not see someone who has less than C4 disease. So if they've got big varicose veins, if they've got sore varicose veins, if they've got a bit of edema with their varicose veins, we cannot see them. That's the government edict. There's a sort of standard letter that goes out. And again, we have to focus our limited resource on the people, a bit like CLTI, who have tissue-threatening disease. So who've got active skin changes, excoriation, eczema, all the way up to a frank ulcer. The only exception to that is if a patient has got less than C3 disease or C3 and less and is having recurrent episodes of superficial thrombophlebitis or venous hemorrhage. And even with that restriction, we're still struggling to get these people in and sorted in a reasonable period of time. There are lots of options in the private sector now that are reasonably cheap, but unfortunately we cannot offer intervention for non-tissue threatening varicose vein disease anymore. So compression, this remains the absolute keystone for complicated venous disease. It's most commonly prescribed or delivered in two ways. Like better for the patients, obviously, is compression garments. For venous disease, these do not need to be above the knee. We would normally recommend class 2. So class 1 being a bit lighter, class 3 being pretty heavy and generally reserved for people with problematic lymphedema. Patients are in control here. They can put them on, take them off, etc. So even if there's a small venous ulcer, we would still prefer them to get compression hosiery because it obviously doesn't need a nurse coming to put on the bandaging. That being said, bandaging is incredibly important for people who are either unable to use compression hosiery or whom have very extensive ulceration that needs bandaging. You will know more than me that we have a very severe lack of appropriately trained, resource in the community, nurses, etc., who can deliver good compression. This is something we know about and will hopefully improve with time. But even if someone gets superficial venous ablation for a venous ulcer, compression will still be the main part of their treatment, and delivering good, reliable compression is absolutely key. Obviously, the ABPI is critical. The NICE guidance is still a big problem on our side. The NICE insisted that anyone being contemplated for compression therapy must have ABPI. This is nonsense, and that it should be repeated every 6 months. That's even more nonsense. Clearly, if someone has pulses, they do not need an ABPI. A trial of light compression going up to high compression is also entirely acceptable, and we'll often do this. Often you can't get an ABPI for various reasons. But yeah, but good compression, no matter what, is without doubt the most important part of managing venous ulceration. We do not, unfortunately, have the resource to deliver an ABPI for everyone with a venous ulcer at the vascular laboratory. It really needs to be something that we are able to offer in community to at least start the treatment with compression prior to assessment in secondary care for venous ulceration. So that's it. I'd be delighted to answer any questions.
Thank you very much. That was a really fantastic update, Alex. I found it really interesting, particularly the CLTI update and the current thinking about plaques, and also the message about statins. As you said, I think we're quite au fait with that, but always worthwhile getting an update on it, and also the thinking that an LDL can be a marker of non-compliance. I quite like that idea as well. Any questions from the floor? I don't see anything in the chat. Does anyone want to put their hand up and ask Alex any questions?
Sorry.
No. Thank you very much. Well, I just want to say thank you, Alex, for your time. That's been really useful, and I hear that the request that as much information in the referral as we can be really useful to help you direct the patient in the right direction. So if there's no further questions, anything else you want to say, Alex? Any final comments?
We're extremely grateful for all of our friends and colleagues in primary care, and if anyone has any suggestions about what we can do better, if we're doing stuff that drives you crazy, and we probably don't know about that, so I should have put my email. It's alex.veazey@lanarkshire. Just please email, feed us feedback with any issues, clinical, whatever. Like I'd be very, very pleased to hear from anyone.
Thank you. That's really useful because it's quite good to have a dialogue, isn't it? Often primary and secondary care were not quite aware of how each other, the constrictions on each other and the resource implications for each other. So it's always good to have that dialogue between us. So thank you very much, and thank you to everybody who has joined us on the call. Another plea for feedback. I've put the link in the chat. If you don't mind filling that in, it just literally takes 2 minutes, and I will share that feedback with Alex once we have it. And this meeting, which has been recorded, will be uploaded to the primary care website in the next 4 weeks or so. So without further ado, I'll say thank you to everybody. A special thanks to Alex, and enjoy your afternoon, everybody.
Yeah.
Thank
Take
you.
care. Bye-bye.
Thanks. Bye-bye.